Thank you, Strack, for the nice introduction. First of all, I want to thank the organizers for inviting me again to Biarritz, which is always a pleasure. I'm really delighted. It's almost feeling like being part of a great family. And I also enjoyed it very much by the three gentlemen who are responsible for the organization here to ask me to deliver a presentation on violence against women addicts. There's not a lot of literature, but I just try to introduce the topic, and hopefully after my lecture we realize that we importantly have to consider this if we are dealing with drug addicts. I have no conflict of interest in relation to this presentation. A lot actually has been published in regard to women's mental health and psychiatric illnesses. We, of course, find considerable information about anxiety disorder, about post-traumatic stress disorder related to experience violence, but the violence itself is not or hardly ever a topic in the literature. This is an overview of my presentation. First, I'm touching the relationship between substance misuse, psychiatric disorders, and violent behavior among women and males. Then the next part is intimate partner violence against substance-abusing women. And finally, screening and treatment intervention for substance-using women experiencing intimate partner violence. So there's a general consensus. The presence of severe mental illnesses like schizophrenia or bipolar disorder increases also the risk of violent behavior. Substance use is a significant risk factor for violence and disturbed behavior. Important confounding variables are existing, like one is the male sex, higher loading in psychopathology, antisocial personality, repeated intoxications, and not adherence with the treatment. There is actually one study, the NESAC studies, and I think I need to use my glasses now. Yes. There are about close to 40,000 people were interviewed in 2 waves. And they were actually looking into the percent of respondents reporting recent violence by type and number of diagnoses. And in the columns give you the number of diagnoses, and the columns present you rather obviously. This is the occurrence in severe mental disorders, like schizophrenia, like bipolar disorder. This is the combination of a severe mental disorder and substance use. This refers to other mental disorders and substance use, and this is only substance use alone. And I think it's very, very obvious that the severe mental illness, irrespective of substance abuse status, were significantly more likely to be violent, and those with severe illness and substance use disorder had the highest risk of violence. In this same study, the prevalence of aggression was not even 1% in the population with no lifetime psychiatric disorder, 25% with bipolar, 11% with substance use disorder, 8% with alcohol dependence. And if you're looking into the aggressive behavior during the last 12 months, which occurred in 2% with no lifetime psychiatric disorder, in 12% with bipolar disorder, 11% with substance use, and 8% with alcohol use disorder. Of course, everybody in the field who is treating patients do know that there is a considerable overlap between bipolar patient and substance use disorder. Antisocial personality is very often accompanied in substance use disorder patients. It's primarily studied in the male population. Females are far less likely than male to meet the diagnosis of antisocial personality disorder. The figure gives you the information in community samples. Substance use disorder and antisocial personality are both associated with violent behavior and criminal offending. There is a study on female felons found the prevalence of substance use disorder and antisocial personality approaching those of male fellows. In the recent study, kind of released by 2010, looked into 130 female felons with 44% violent offenses, representing 32% antisocial personality, alcohol dependence, and 72% substance use disorder. And if you look into this special population of the felons with antisocial personality disorder, the prevalence of substance use disorder is rather high, related to alcohol, cocaine, and opioids. But not only looking in the substance use pattern, but also looking in the prevalence of common comorbidities. They are pretty high loaded. And the conclusion was that females do show more psychiatric comorbidities than incarcerated males, with a mean violence score of 2.4. And what's the last one you cannot read? What's the major question is, how do we diagnose this? In this, in prison, is the focus primarily related to crime? Do we diagnose the psychiatric disorder, the substance use disorder, and how do we treat them? This is an example. In my clinic, we did an investigation in opioid-maintained patients looking into health-related measures, which means this is sentenced by court, not being forced to go to prison, and compared this group with patients, with substance-dependent patients in the prison. We got structured interviews, medical, psychological, legal data, also related to the Narcotic Substance Act. And the focus was, of course, related to the indicators, what made some person being sentenced to health-related measures, being treated out of jail, and others being in jail. The sample consisted of 96 opioid-dependent individuals, a minority of women. They were either inpatient or outpatients in their treatment, and they had structured face-to-face interviews like ASI, ASIC crime, and were compared to a prison sample with also an equivalent lower amount of women. And this is just to give you an information, as usually in the dimension violent behavior is never picked up. If you look into the items, problems controlling violent behavior, almost 50% were forced with this problem and could not deal with it. In addition to a very, very high loading of other psychiatric patterns. Coming on to intimate partner violence. This is a type of violence frequently experienced by female addicts. 20 to 50% of substance-using women, including those in substance abuse treatment, have experienced intimate partner violence in the past year, 3 to 5 times higher than prevalence rate found among the general population. And intimate partner violence victimization may heighten the risk for continued drug reuse and recidivism, serious mental and physical health consequences, and mortality in substance-using women. This is an example I'm presenting, and I was actually looking into the area related to one of the topics of this conference, of the risk of injection to get infected either with HCV or HIV. This was a European Union study trial with several sites in individual countries in Europe, with the title Reducing Hepatitis C Injections and Sexual Risk Behavior Among Females Who Inject Drugs in Europe, Translating Evidence into Practice. 231 women were investigated who injected illicit drugs in the previous 6 months. And one of the items was to measure the HCV transmission knowledge and HCV risk behavior among females who inject drugs. The other items who are relevant for this presentation are the educational part. The high prevalence of HCV infection among women who inject drugs is a result of regular behaviors for HCV transmission, like sharing needles, syringes, injecting in groups or with a partner, and the involvement in high-risk violence partner relationships. The dissonance between the knowledge and the behavior is explained by several items. One of them is that intimate partner violence increases females with intravenous drug abuse vulnerability to inject risk behavior, to injecting risk behaviors, and reduces the ability to negotiate and assert safe injection practice. And of course, it goes along with an increase of the psychiatric comorbidity. And what was the result? 70% of the participants had experienced intimate partner violence in the past 12 months of their current or most recent development. What type of intimate partner violence occurred? 40% reported about severe combined sexual and physical abuse, 16% of physical abuse with emotional abuse, 11% emotional abuse and or harassment, and 4% physical intimate partner violence without any other form of violence. I give you just an example, a qualitative example. We had qualitative standardized interviews of two of the women. One stated, "I'm too scared to say to him, I don't want to use yours," meant on the syringe, "in case I got another smack in the jaw." Another woman stated, "He refused, in quote, could use a condom furthermore. He hit me in the face. I was afraid I couldn't say, use it twice." Many of these statements, and very often in our daily routine and daily life of treating addicts, we keep forgetting the important issue of intimate partner violence. There was 2010 an article in Nature putting gender on the agenda, which was more or less directed towards the biological aspects, stating medicine that is currently applied to women is less evidence-based than being applied to males. But at the same time, they also stated very important aspects related to gender, that one of the important things is also bringing women to higher rank of research, to participate in prominent meetings in order to address women's sensitive issues. And that's the end. What can we do? Yes, it's obvious. It's not just because of the health, the physical and psychological health of women addicts to address intimate partner violence. It's equally important to also take the example of preventing further HIV infection or HIV in this very malignant dependent relationships. So there are several models who refer to the importance of screening in facilities for intimate partner violence. An increased identification would need, and this is actually the action what is required from the health plan, would need adequate persons that the patient can be referred to. Not only into medical, but into a broader concept of the medical, psychological, and social area. Intimate partner violence screening should contain the following evidence-based components. First, identification. Second, raising awareness of the co-occurrence of intimate partner violence, substance use, and conducting safety planning. Third, increasing motivation to reduce intimate partner violence, to do some goal setting and referrals to women to appropriate facilities, and cover this also in substance use services. And the last aspect, finally, is very important. It should be taken care of that there is enough female staff present in order to cover this sensitive topic. And there was actually one review published last year by a colleague from working with Martha Torrance. She did a systematic review and meta-analysis of research-controlled trials who tested the efficacy of intervention, cognitive behavior therapy, and advocacy to reduce intimate partner violence among different populations of women. She found 12 research-controlled trials who were eligible for the review process. Cognitive behavior treatment is very well known to the audience, so I do not need to go into details. Advocacy was more or less legal advice, information, housing, but without any psychotherapeutic counseling. What were the results? Both cognitive behavior therapy and advocacy intervention resulted in significant reduction of physical and psychological intimate partner violence. However, there were quite some limitations, small amount, heterogeneity of intervention. The sexual intimate partner violence was not reduced by either advocacy or cognitive behavior therapy in the few studies considering the outcome. And only one of the 12 research-controlled trials included in this review was found to be effective in reducing intimate partner violence among substance-using women. So it was the conclusion, we of course need more standardized research to cover this topic. There's new development. It's very difficult. We do know in the whole medical field, males have a higher retention if it comes to treatment, but not in substance use disorder. Women are disadvantaged in many aspects. They come later, they have the telescoping effect. If they come, they have all the complications earlier, faster. And they do have the sensitive issue of violence, especially intimate partner violence. It's very difficult, very often in settings, to properly address this. And there is a growing evidence that computerized screening interviews are effective in increasing rates of intimate partner violence disclosure among women in healthcare settings. There is a model which has not been tested so far in substance-using women. The American friends here might know this initiative, which is called WINGS, Women Initiating New Goals for Safety. WINGS is a self-paced assessment intervention that seeks to improve safety and encourage healthy relationships among substance-using women on probation in community court settings, and the intervention seeks to identify women at risk of intimate partner violence, conduct safety planning, enhance social support, and access to service to prevent intimate partner violence. And this is actually a project which is funded by NIDA, and the aim is to conduct a research-controlled trial that will test the feasibility and preliminary effect of a multimedia version of the tool compared to a non-media version of the same intimate partner violence screening, brief intervention, and referral service delivered by case manager. And the main interest is to test whether women in a court situation will be more readily disclose intimate partner violence to a computer than a caseworker they are meeting for the first time. That's my presentation. Thank you very much. And I hope we all consider this in the future. Thank you very much.